Good afternoon, everybody. I'm absolutely delighted to be chairing this afternoon's webinar here at the Royal College of Psychiatrists. My name's Dr. Trudy Senavaratna. I'm the registrar of the college. We have an absolutely amazing lineup of speakers for you through the webinar, which is called Physical Activity and Mental Health Through Social Prescribing, Why You Should Be Excited. And I feel very excited because I know that certainly this week in my review of my patients that I'm looking after, this was a really important topic for each one of them. We'll be having some questions, so there is a Q&A time at the end, so please do post questions. I'm delighted to see there are lots of you listening in today, so thank you for finding time to join us today. So moving on then, I'd like to start by introducing Dr. Catherine Kennett. I'm delighted that Catherine is joining us, and she's going to start with an introduction to social prescribing. She's done fantastic media work through the year and last year, and has helped with the position statement for the college. So Catherine is a consultant in child and adolescent psychiatry, working in North London, and is the social prescribing lead here at the college, at the Royal College of Psychiatrists. Catherine has an interest in health policy with a focus on identifying environmental and sustainability issues as a key social determinant of health. She has authored the Royal College of Psychiatrists position statement on social prescribing, is an active member of the college's Sustainability and Planetary Health Committee, and presents regularly on sustainability mental health. Thank you, Catherine, over to you.
Thank you, and thank you so much for having me here today. I'm so excited that we're doing a webinar on social prescribing. So I'm going to start us off today by telling you over 5 minutes about social prescribing and what it is and why you should be excited. So, social prescribing, it's one small part, but important part, of making a truly sustainable mental health care system. One where there is a newer, a greener gold standard of care. One which offers more, not less, to individuals, to the planet and to the society as a whole. So what actually is it? Well, social prescribing is a way of connecting individuals to groups in their community. So groups can be pretty much anything. They can be skill-based, such as a knitting group, a craft group, drama, pottery. They can be nature-based, so such as green walking groups, bird watching groups, or gardening. Or they can be, as we're going to hear about today, activity-based. That can be anything from walking groups, green space and urban spaces, walking groups, football groups, or any kind of sport or activity you can think of. There's growing evidence that social prescribing can improve symptoms of mental health disorders for those with mild illness, but also support treatment, recovery, and relapse prevention for those with moderate to severe mental illness as well. But that's only the case when they're used as part of an integrated part of a biopsychosocial healthcare system or healthcare approach. What I mean by that is it's an add-on. This is not a replacement to traditional mental health care. This isn't instead of medications where they're integrated, or talking therapies or occupational therapies. This is very much an add-on that can really help our patients in pretty much all situations. The classic social prescribing pathway looks like this. So an individual can either self-refer, they can go to their GP, which is the more traditional route of referral. They can talk to their psychiatrist, their community mental health nurse, or their teacher, or pretty much anyone. They can be referred to a link worker. A link worker is an individual who's not a psychologist, doctor, or nurse. They're somebody whose job is to listen to individuals and be based in the community and know all the local groups and what's going on. They're often based physically in GP practices or in link worker centres. They meet an individual for a one-off session where they ask the question, what matters to you? And based on what the individual wants and what they're interested in, means that they can based on what they're interested in, means that they can signpost them to local groups in the local community that they know exist. Rarely, social prescribing link workers can often support individuals in getting to sessions, to groups if it's really difficult, such as someone has anxiety, for example, they might have more than one session. Traditionally, social prescribing has been the remit of primary care, but thankfully we're now starting to see real evidence and real change where it's being incorporated into mental health care as well. And it's on us as psychiatrists to really support patients in access to this key work that can really make a difference to our patients. How does it work? Well, the more social identities we have as individuals, the more resilience we have to mental illness. So, for example, I'm a psychiatrist, but I'm also an actress in my spare time. During the height of lockdown, I was a balcony vegetable gardener. And in case you might have heard that, I'm also a kitten mother. All of these social identities mean that if one of those identities is challenged, such as if I were to lose my job or be unable to be so physically active through illness, for example, that I have other identities that help me be resilient. Social prescribing, when done well, is empowering for patients. It's one of the few things in mental health care that's truly patient-led and truly empowering. No one can be forced, and no one should be forced to attend social prescribing groups if they don't want to. They can only go if they really want to and find them exciting and interesting, with support often. Social prescribing can be transformative, creative, empowering, and powerful. It can be helpful to nearly all patient groups of all ages, at all points in the patient journey. But obviously, the needs of patients is going to have to be taken into account. For example, young people in the community suffering with anxiety are going to have a very different need from groups, social prescribing groups, to older adults with memory issues, or those who are inpatients, for example, in medium secure forensic wards. That doesn't mean that they can't access these groups, just that they really need to be thought about. If you're interested in social prescribing and you're excited and you want to get involved, please, I implore you, look at your local community, speak to local GPs, speak to NHS England if you're struggling to find link workers, and link up with them and make them a part of your treatment for your patients. Thank you very much.
Catherine, thank you so much for that wonderful introduction, just to get us into the flavour of what social prescribing is. I mean, we use this term, but actually just to really understand what is possible. And for psychiatrists, really the importance of how they can facilitate this. So a really lovely introduction, thank you. And there's a message from Kezia here, just saying, please, reminding you all, please do post questions as we go along, as well as chatting as we go along, just to make it a really rich discussion. I'm delighted now to introduce Dr. Kaz Narman, who is a child and adolescent psychiatrist who's working with teenagers who have an eating disorder. She was on the executive committee for the eating disorders faculty at the Royal College of Psychiatrists. She is currently deputy chair of the RC Psych Sports Psychiatry Special Interest Group, and is also a member of the the International Society for Sports Psychiatry, where she completed further training in sports psychiatry. Dr. Narman has an interest in athlete mental health and eating disorders. She is co-editor of a book, New to Eating Disorders, and has a chapter, she's the chapter author of a book, Case Studies in Sports Psychiatry. Thank you so much, Kaz, and you're going to tell us, your talk is titled Promoting Physical Activity, promoting physical activity through social prescribing. Thanks, Kaz, over to you.
Thank you. Katie has kindly agreed to share my slides for me because I'm doing this from work on an iPad. Could we have the next slide, please? I'm going to talk about why physical activity is really important, and I'm also going to talk about why it can sometimes be hard to do the physical activity. Next slide, please. We know that physical activity is really, really important for both our mental and physical health, and that the Chief Medical Officer has, based on research, brought out guidelines that we should all be aiming to do, and that is to obtain our ideal physical and mental health. There isn't time to read the research behind it, but it's quite easily accessible for those of us who are interested. Next slide, please. If we look at a sort of evolution of humankind, until recently, we had to be physically active in order to survive. We had to have a certain amount of activity, and it's been hard to study, but there's been studies of both hunter-gatherers and subsistence farmers. And generally, the hunter-gatherer tribes would be doing 2 to 3 hours a day of moderate physical activity, which is similar to what a factory worker would be doing nowadays. So subsistence farming was really hard for humans. It was much tougher, much longer hours, a lot more work. On the right is a picture of one of the Tamuhara Mexicans who are subsistence farmers, but they have physical activity races from time to time. We know that rest is also important for growth, body maintenance, building up our stores of energy, activity, and reproduction. So there is some idea that we're born to rest, but we're also born to be active. Next slide, please. We know that in our patients with mental illness, there's a massive mortality gap. For men, it's 20 years, females, 15 years. We know there's more smoking, more obesity, and less physical activity. And we know there's also a link between some of the medications we use and weight gain and diseases as a result of that. And again, there's a lot published about it. Next slide, please. So we know that there are all these risk factors in our patients, often quite unhealthy lifestyles as part of it, and that this is contributing to excess deaths, both in our patients and in the general population. Next slide, please. However, we also know that physical activity is not just good for our physical health, but it's also good for our brains. We know that regular physical activity increases grey matter volume, and some of those areas are some of the areas which are impacted on by anxiety. We know that there's also changes and improvements in connectivity of white matter and an increase in regional white matter volume. We also know that there's structural changes, and we know that physical activity is associated with neurogenesis, angiogenesis, and synaptogenesis. And all of these things have to be good for us. We also know that it increases our levels of BDNF, which reduces neuroinflammation. There's not enough time to discuss because there's ideas about different types of physical activity being more effective, et cetera, but we know that physical activity is just good. Next slide, please. We also know that physical activity has important benefits to our psychological well-being and to things like cognitions, attitude, a sense of mastery, self-acceptance and growth, as well as benefiting mental illness as well. Next slide, please. We know that there's a direct impact on mental illness symptoms, but we also know that there are psychological benefits, and as described by Catherine so beautifully about distraction, social interactions, self-efficacy, reducing social withdrawal, improving self-esteem, and it also reduces our anxiety sensitivity. Physically, we know that there's reduced inflammation, and there's a lot written around antidepressants and brain inflammation, and we know that it improves mood, motivation, stress response, and memory formation. So there's an awful lot of benefits to our patients. Next slide, please. But why is it so hard to do? Why is it hard to start? Well, to begin with, when we start physical activity, if we haven't been doing it for a while, you have a lot of discomfort and you set about those negative feedback loops. So you're dealing with discomfort with minimal sensation of reward. Because we never evolved to be inactive and out of shape, those adaptations from physical inactivity mean that it only becomes rewarding after doing it for a while, and we think about weeks and even months of effort. We know, for example, with dopamine, that less activity leads to less dopamine receptors, and those who are more overweight have less dopamine receptors. So we kind of lose that reward. We also know that that reward only happens after exercise, not before. So we need to get off the couch to then get that reward, but we need to be getting off the couch over and over again to get that reward. We know that non-exercisers have lower serotonin activity, so it's harder to get that motivation to move. We know that also those endorphins, which give us that feel-good factor, only happen after at least 20 minutes of exercise. So you need to be fit enough to do that exercise in the first place. And again, those endocannabinoids, which make us feel so good, happen only after fairly long periods of activity. However, if you can get that exercise started in the beginning and have people nudged and have those social things and the social factors happening, it becomes a habit, and then eventually it becomes, we get that positive feedback loop and that reward. So in the beginning, it is hard. It's even harder for our patient group who might be socially isolated and might really be struggling. But actually over time, if we can promote that, it will help our patients. How do we help people become more physically active? Next slide, please. By having a social component led by someone qualified, activities that are fun for the individual. If it's dance, if it's playing games, if it's something that's outdoors, if it's something that's fun, if there's variety, if it's somewhere beautiful. So we need that nudging and that coaxing and removing some of those obstacles to exercise to really help benefit our patients, and we need it over a period of time. And I guess we're going to be talking with Nicole about some of those barriers and facilitators to exercise, but actually we're also going to be thinking about opportunities for our patients. Thank you very much. I'm handing over to Nicole or Nicoletta now.
That's lovely, Kaz. Thank you. That was an absolutely wonderful, wonderful talk. There are a couple of questions coming up after your talk. I'm just wondering whether to, I think I'll leave them till the end, apart from one quick one, perhaps before you go. But there's a question saying, what's BDNF?
So BDNF is brain-derived neurotrophic factor, and we think a lot of the antidepressant benefits are through production of this neurochemical. And it helps us grow new brain synapses. It helps our brain cells be healthy. And it's one of the mechanisms by which medication works, but it's also one of the things that benefits our brain and mental health.
That's wonderful. Thank you. I think that will help put that into the context for the person who posted that. Kaz, thank you so much. There are more questions for you, but we'll come back to that at the end of the other talks, if that's okay.
Cheers.
Thank you. And next, we're going to move on to Dr. Nicoletta Lecker, who is a consultant psychiatrist in Sheffield Health and Social Care Foundation Trust. Nicoletta works in acute inpatient psychiatric services. She's a member of the executive committee of the college's sport and exercise special interest group, and is in the role of aesthetic, sports and dance liaison. She's also a member of the International Association for Dance Medicine and Science, Dance for Health Committee. It sounds really exciting. And Nicoletta, you're going to be talking to the enablers and barriers to inpatient mental health physical activity and from a staff's perspective. So thank you very much. Over to you.
Oops. Sorry, a little bit. Here I'm sharing my screen. Thank you very, very much for inviting me today. I will speak about acute inpatients. That's a group of patients we often don't think about. I think physical activity is something that can bring a sense of normality on wards, both for patients and staff. And it's a real opportunity for staff to connect with patients as people. It's evident that staff's attitudes can influence how they engage with patients. So we thought to explore what are our staff's perspectives about physical activity, and from that to talk about enablers and barriers in inpatient mental health. So we started by bringing a group of people together. We tried to keep it multidisciplinary as much as possible. We had doctors, we had consultants, trainees, occupational therapists, physiotherapists, nurses, and we asked each of these people to talk to their colleagues and help us in designing this staff survey. So we explored physical activity on acute wards, the staff's perceptions and attitudes, and we came up with some suggestions. We used an anonymous questionnaire we designed on 2 acute general adult wards in Sheffield. We asked 85 staff members, again, MDT, 54 replied. That was a very good response rate, 63%. we were really, really pleased to see that everybody saw physical activity as very beneficial to physical and mental health, 100% agreement. But when we started looking at the practical things on day-to-day work, and we asked staff if it's easy to engage with service users in their day-to-day shifts, they said they didn't have the time. They had limited equipment. The equipment was outside the ward, and as most people were detained, they couldn't get out to use them. They said that it wasn't part of their job role. They had other things taking priority, didn't have confidence in their skills. And also they saw many service user barriers. I suppose lack of motivation was one. I don't see it mentioned here, but it's something that came up a lot, comes up a lot. They talked about the violence, aggression, high turnover, and not having leave. We asked if staff encouraged or accompanied service users to physical activity sessions. Very common response, they can encourage patients, but they're unable to accompany them. We asked them if they exercise regularly themselves. 70% they said they exercise regularly. Of course, we thought if the people who replied, they were the ones who were interested in physical activity, hence the high rate of exercise. But they also said they don't exercise as much as they want. They wish they had more time. They wish they did more. They spoke about lack of time, exhaustion, high workload, and lack of motivation. Then we asked staff what stops them from helping service users do more exercise. They said they don't have enough time. Again, they spoke about motivation and also finding activities that detained patients can do. And then we started thinking about what could help. And we asked what would help staff promote physical activity on the ward. They spoke about resources. I think when they say resources, they mean, I suppose, types of activity that can be done inside the wards and you don't have to go out. Access to gyms, gardens, staff dedicated to physical activity, and staff trained. Some quotes from staff's responses. They spoke a lot about a more relaxed environment. And here you see the wards as we imagine them to be, and we wish they were not, with a high turnover, aggression, violence, incidents, paperwork, etc. But a very important quote for me was somebody mentioned a change in culture. And they said if physical activity was valued and promoted as much as medication, talking therapies, and other therapies, other interventions, and if service users were encouraged daily by all, not just OTs, then people might engage. We asked staff what physical activities on exercise they have done in the past week, and they said none. 75%, that was quite high. And then they mentioned some other activities like walking, gym, football. And our last question was about what they would like to see introduced onto the ward. They spoke about things that seem simple to us, but in effect, when you are inside an acute ward, they're not. They spoke about walking, running, yoga, gym, swimming, dance. So our suggestions, we thought that we needed to highlight the change in ward culture, valuing and promoting physical activity. We thought that daily encouragement by all MDT members, not just by the OTs is important. And we thought we need to change our perception of physical activity. We need to see it as a real public health problem and see it as something that needs to be promoted as part of people's mental health treatment and as a physical health strategy. And one of our main concerns was what happens after people get discharged. Even if they're introduced to some activities when they're on the wards, do they continue? So this is the role for social prescribing. and the need for clear referral pathways. Thank you very much. Thank you for listening.
Nicoletta, thank you so much for that brilliant talk. I was imagining all those activities happening sort of across all our inpatient environments, you know, across all ages. It would make such a huge difference, wouldn't it?
Absolutely, yes.
To people's sort of recovery and quality of life, and to be able to then sustain that when they're at home, when they're well, hopefully, and keep them well.
Absolutely.
It would be a real sea change if we could see some of that. It would be amazing. So we'll come back to some questions later. So thank you so much for the moment. And moving on then to our next speaker and final speaker, who is Kenny Butler. Kenny, I'm so thrilled that you're with us. And thank you so much for coming along to speak with us. So Kenny leads on UK Active's health and wellbeing development, linking the fitness and leisure sector to health and social care. He is a qualified physiotherapist with a keen interest in social prescribing and the active aging space. He aims to align the fitness and industry sector to be a front line of the NHS and embed activity as a way to promote health equity and give people with long-term health conditions choice to be active physically and socially. So Kenny, I shall hand over to you and let you talk through whatever you're going to talk through. So thank you so much.
Thank you very much. Thank you for having me. I'm slightly intimidated with all these clinicians and practitioners around, but I will crack on. Yeah, real privilege to be talking to the college and this audience about something that's so important, especially in the current health climate. My name's Kenny Butler, as Trudy said. I'm the strategic lead for health for UK Active. I'm going to try to illustrate the potential of the fitness and leisure industry for social prescribing, and to get you excited about helping your patients in practice in this space. So first of all, as I just wanted to describe a little bit of who we are. It's a membership body at its core for the fitness and leisure sector, but we got a much wider health remit plus a research and policy function. What do we have to do with social prescribing? You might ask, which is a pretty good question. Well, one answer is on this slide here, where we aim to get more people more active and promote health equity and promote opportunities to become more active. And social prescribing is one of those touch points. And next slide, please, Cassia. Thank you. And why should social prescribing pathway, why should the fitness and leisure sector become part of that pathway? Well, these are some examples as part of the ambition to contain demand on NHS services. Discussions and resource have been shifting toward prevention, as you guys probably know. And scaling evidence-based behavior change interventions is one key aspect. So many sectors are getting involved. And just to pick out a couple here, DEFRA, for instance, which has been alluded to already with green prescribing, announced a £4 million investment in cross-governmental project aimed at preventing and tackling mental ill health through nature-based green prescribing. The money and pension services, we know that there's a relationship between finances and health. So the money and pension services are involved with this to help people with financial advice. The one on the top left there, the English National Opera, have developed a Breathe program, which is a pioneering singing program, you know, specifically for people for COVID, for recovery from COVID and COPD, and combining that medical and musical expertise offers a pretty unique experience. So people referring into that opera and arts industry. So it's arts, government. So now it's time for us to take that stance in the sports, leisure, and fitness, physical activity sectors and other community activities to get people active to support the NHS. Next slide, please, Cassia. Thank you. So Kaz has eloquently outlined the benefits of physical activity. Nicole's talked about the enablers and barriers. But here's the potential of the industry to get people more active. We've got 7,000 facilities employing over 400,000 exercise professionals. And, we deliver physical activity to over 10 million people every year. So there's real potential for the industry to become part of the social prescribing pathway to help people who are more vulnerable, to help people who have that need to become more physically active if they're on that behavior change scale. 80% of the population live within 20 minutes of our sites. That's pretty powerful, especially with the winter coming up and the nation being deconditioned, having been cooped up recently. And that there's some big numbers there for social value, and that's based on Sport England and Sheffield Hallam University's work around what's called a social value calculator, which evidenced the social value of physical activity and improved health and subjective well-being, increased educational attainment, and things like reduced crime through being active in our sector. Next slide, please, Kessia. Thank you. There's such a huge opportunity here to drive the development of strong partnerships with the NHS and other health agencies and colleges like the Royal College of Psychiatrists. We currently have a breadth of programs that have a direct role in improving the nation's mental health and physical health and social well-being. Already we have cardiac and pulmonary rehab occurring in our spaces. 66% of cancer prehab occurs in our spaces. Second to walking and incidental activity, we're the biggest driver of participation in physical activity in the country. So that's pretty big activity levels already. However, it can be bigger by developing robust pathways like social prescribing. Another piece of work that I'm doing is linking community rehab into our spaces. Already, rehab was coming out of the acute setting prior to the pandemic, even more so now to help with the 5.5 million people on a waiting list. So those are a couple examples of pathways. So in this slide there, it says choice and control. Really important words in this whole equation. People can be active for more than physical health. They can be active to be emotionally and socially connected in our spaces. They can be creative through art in our spaces, moving the kit aside in these gyms. Gardening. Some of our members run public libraries in addition to gyms. So, the people can connect with group classes, and you can't underestimate the power of pair groups as well. Or people can purely come to be physically more active and improve their physical health. So real powerful options here for the social prescribing pathways, just like they're doing with the arts, just like they're doing with DEFRA and green prescribing. And I say this is the National Academy for Social Prescribing and NHS England and colleges like yourselves. Next slide, please, Kessia. So now before the pandemic rudely interrupted all of us, we made an announcement in 2020 about offering the NHS 500,000 hours of free activity within our spaces. And that's going to kick off next year. Just for context, this equates to about 100,000 people having access to our spaces for 5 one-hour sessions, just for context. It's not going to be as prescriptive as that. So we did announce that to the NHS, and we have members who have put themselves forward to honor that. And we've done a consultation recently to assess what social prescribing is occurring in our spaces, and refreshingly, there's a lot of it. And, in addition to what as GP referral. So, at a time when the NHS and social care systems are coming under such increased pressure, this preventative approach will be a game changer. And we aim to diversify these programs and linking them into healthcare, into thousands of the gyms and pools and leisure centers that exist within every community. Like a post office used to be center of the community for a generation, community centers and leisure centers can be a real center for health. So we're bringing forward various nationwide models for local commissioners for primary and secondary care. And this is one, social prescribing, to link into this pathway. Next slide, please, Kessia. Thanks. So what are we doing? This is probably something that you want to know, in addition to the potential that I just spoke about. As I mentioned, we did a consultation, sector-facing consultation over the summer. We're going to release that report on October 13th at our conference, face-to-face, City of London Guildhall, if you guys want to come. It's on our website. Sorry, I didn't mean to plug that, but we are mapping with NHS England, with the primary care networks and the ICSs, and matching gyms and leisure sites to the NHS link worker network that's being developed and promoted as we speak. In early 2022, we're going to test some sites. So, we've got a region of operators in the West Midlands or something like that, or Greater Manchester. And we're going to match that up with some pathways that are existing and promote those links, but also to develop new ones as well to feed into the social prescribing pathway, to bring people into our spaces. Now, the pathways, I've got some blue stars there on a few because we're still working that out with NHS. But the obvious place to go with social prescribing are link workers who are having those conversations with people. The new technology in town, the conversations. And they're embedded into the ICSs and PCNs. So, but that's not the be all end all. You guys are probably more interested in what we could receive from the community, mental health nurses and psychiatrists. And I've been talking to the college about that and how we will develop that with the NHS. And I'm going to bring that to the NHS and say, look, there's a real appetite here to help patients and the practices with this from the college. So how can we embed that into our pathway, into our project next year? Inpatient mental health, of course, could be another place to come from, and self-referral, self-management. We really want to have that people, to allow people to come through there. Now, I know you guys know about IAPT. I don't know it about intimately, but maybe there's a way of linking into that, which is one of the biggest programs in the world, my understanding is. So that's a bit of a whirlwind tour of what our sector at UK Active, membership bodies representing these thousands of gyms, are driving toward bringing our sector to health bodies like yourselves, like NHS England, and say there's underutilized space out there. There is space. There's professionals that talk health already. Let's work with you and help people become more active socially and emotionally. And that's me. Thank you.
Kenny, thank you so much for a really inspiring talk and for telling us what you've been up to, and also more about UK Active and the huge opportunities that are there. And so thank you. So let's move into some questions then. So we've got a good amount of time for some questions, and thank you all for posting. Please do keep posting more questions, and we'll hopefully get through them all. So perhaps one for Kaz to start with, and I believe this sort of appeared during your talk. Kaz, there's a really interesting question here about genetic differences in people. Are there genetic differences in the amount of physical activity that an individual undertakes?
Absolutely. I mean, it's hard to know the sort of difference between genetics and some of that epigenetics. So we know that, for example, if children are active and then they become active teens, they tend to carry on being active adults. But there is a spectrum around physical activity. So, for example, people who develop anorexia nervosa and restrictive eating disorders, genetically genes associated with physical activity or high levels of physical activity are expressed. There are definite genetic differences around it. But it is also around, those not doing that physical activity leading to less physical activity. So it's complicated, and it's both.
Thanks, that's really helpful. And just perhaps follow on to you, Kaz. Someone thanking everybody for their excellent talks, and I'll thank you all again at the end. But thinking of that biopsychosocial formulation and the social determinants of mental health and mental illness, and what trainees could be doing at all stages, is there, how trainees incorporate that into their work? Have you got any suggestions about how trainees can just roll this into their formulations and how they're working with our service users and carers?
I think formulation is sometimes, almost as we get busy, becoming a bit of a lost art. So I think it's really important to include that and look at things like social inclusion, physical health. There's other parts of sort of wider health. But if trainees are looking for a way to start those conversations, there's a website called Moving Medicine, which tells you if you've only got 1 minute to have a conversation, what might be the questions you might ask. If you've got 5 minutes to have a conversation, how might you ask those questions? And I think that sort of nudging and encouraging is really important. And it's almost part of behavioral activation, which we know is really good in both depression and psychosis and all those other mental illnesses. So if we incorporate that into also people's prior identity, what were their hobbies, what were their interests, what used to make them happy, how can we help support them to get back to that? But by all means, look at the Moving Medicine website. And I guess if trainees also want to join the sports psychiatry special interest group, as well as the social prescribing one, there'll be a lot more.
That's lovely, Kaz, thank you. And a question that perhaps all three of you can answer, but maybe I'll direct this to Nicoletta. Does the timing of physical activity have any bearing on sleep?
That's an interesting one, because it works differently for different people. And I think Kaz, who maybe has looked at the bibliography, can say something more than empirical.
So it can do. So intense physical activity at nighttime can definitely impact on being able to fall asleep, because you get all those sort of hormonal and endocrine changes that really can wake people up. And I think it's particularly important in conditions like bipolar disorder. So the timing of it is important, but it doesn't mean that doing, for example, some yoga at nighttime would be a terrible thing. But you don't want to do high intensity interval training at 9 o'clock at night.
No, I can't think of many people who might, but there are some people who might want to do that. But certainly the manic person might do that, mightn't they? Kenny, did you have any thoughts about that one? Physical activity and sleep and timing?
Well, we prescribe exercise and we promote exercise for the reasons of endorphin release and promoting that. I mean, I don't know about you guys. It tees me up for the day if I do it in the morning, and I feel more alert and I feel more cognitively ready for the day, right? So with that in mind, I totally agree with Kaz that the high intensity stuff will probably keep you awake because that's going to be running through your system. But the lower intensity stuff could be quite relaxing, and that is for me as well. That is exactly how I exercise.
Yeah, but if I could add from my personal experience, and that's why I said it works differently for different people. When you are in an intense environment and you are somehow work at a very high level each day, maybe if you exercise at night, it helps you calm down. It depends on the type of exercise.
Yeah. Very subjective, isn't it?
Yeah.
I mean, Nicoletta, you also talked about motivation in your talk.
Yeah.
How do we sort of help that motivation issue? Because we know that can be an issue, but that can also be a product of the environment, can't we? So what can we do differently to help with the motivation?
That's very, very true. And I think this was one of the triggers for us to do this survey. The reality of life, especially on acute wards, is people sleep, for example, until 1 o'clock. Not doing much. We did a short patient survey, and I saw the question about asking patients, and they said because when they're on the wards, they can't go anywhere. Actually, their physical activity level decreased Before they came in, they were walking everywhere, as many were not driving. So the motivation, I think, and again, I will not refer to evidence, but I think role models, as all us are acting as role models, promoting physical activity, not just talking about it, but doing it, can help people somehow get out of their beds. It depends on the way you talk to people. I know we're talking about one conversation, 2 minutes, but these 2 minutes, if they come across as genuine, enthusiastic, authentic, then the patients might listen, and they do listen to doctors, because we are seen as the people who prescribe many times. And when we talk to them about physical activity or art or other things, sometimes they're taken aback. And as I said earlier, we connect with them in a different way. So motivation. Another point is the social value of physical activity. Many times we see externally somebody being unmotivated, but they might have other issues, for example, social anxiety, or they've forgotten how to be in groups. We don't realize how much physical activity helps with social health.
Thank you. And just perhaps another one for you, Nicoletta, a question around, did you ask the patients as well on the ward what they thought about exercise?
Yeah, we ask them regularly. Even yesterday was National Fitness Day, and we did a whole, somehow, I think a lot of our, a part of our weekly community meeting was dedicated on that. And the responses are overwhelmingly positive. There are the people who say, no, I can't do it. And there are reasons for that. But most people want to engage in physical activity. Why they don't want to do it? I suppose it's the sad reality again. Sometimes when we think of physical activity, we think of somebody really good looking, really fit, really this, really that, dressed in, they're probably in great clothes. So they've got a certain physique, and our patients don't feel they fit with that. And how can we break that barrier down and say physical activities for everyone? And the goal is not to look like that, but it's a much more complex goal. So to come back to the original question, yeah, it's we do ask patients regularly about physical activity. Things have changed. This survey is a few months old. Some of the things have changed. For example, we've introduced things like chair exercises on wards. We're having a dance movement day on October the 8th. So we are trying to do whatever the survey told us to do.
Lovely, thank you. So this is quite a big question, and I don't know who might want to answer this, but perhaps Kenny might want to start. But how widespread or how common is social prescribing in the UK?
I can come in on that if you'd like.
Go ahead, Catherine.
Yeah, so really widespread. And I think it's quite shocking and quite sad that we as psychiatrists and clinicians in the mental health world often aren't exposed to it unless there's a link up that's already there. So I saw that question come in and was very excited and quickly looked up some figures because it's actually
well
done. Well, it's really widespread. So there's a target in England, and I will come to outside of England in a moment, but there's a target in England set by our government that by 2023 to 24, that financial year, every GP practice in England will have access to a link worker, and we're getting there. So to help that happen, every primary care network, PCN, with a population over 30,000, I think that's most of them basically, will be reimbursed the cost of one link worker, and it goes up above in bigger populations and it gets over 100,000. So it doesn't cost the PCN anything. So there's a massive push for this in terms of preventative medicine. And in 2019, there was the National Association of Social Prescribing, National Academy of Social Prescribing was set up, which cost the Department of Health and Social Care £5 million, and it's been given an awful lot of resources. That's the body that supports social prescribers that are link workers who are already in post. And the long-term plan, released in 2019, massively supported social prescribing and put it's one of the key parts of the personalised care pathways, the personalised care plan. It's one of 6 elements of it. So this is big, and it's everywhere in England. The other nations within the UK have also committed to it in a slightly less concrete way. If you're interested in Wales, Scotland and Ireland and their commitment, you can look at the very readable social prescribing position statement that we released in February, that's available on the website to look at the specific commitments, but they're a little bit behind England. But if you're interested in looking in your area, I implore you at the end of this webinar or now to Google your area and social prescribing, and you will find a way in.
That's brilliant, Catherine, thank you. That's great. Kenny, did you want to add anything to that?
No, there's some great stats there. She's very well prepared. It is the biggest investment in any health system in the world is made in social prescribing. And people like James Sanderson, who's the director of personalised care at NHS England, really want to have, what we're doing here and what the ENO are doing, the DEFRA, those other sectors. They want to have that as a pioneering sort of world model. They want to export that as well, which make them look really good, but it is a huge investment. And I think 6 million people are going to benefit from that by 2029, of which social prescribing is one bit. Personalized care is multiple things, wheelchair provision, etc. But social prescribing itself is quite a movement.
Yeah, brilliant. Thank you. So there's lots of questions appearing, so I want to try and get through as many as we possibly can. The next one is, I'm a core trainee, and also, perhaps this one, Kenny, to you too. I'm a core trainee and also a strength and conditioning coach. I have a CrossFit L1 qualification for medical professionals. I consult for Senko in a school on movement exercise for mental health. Is there any financial support, incentives, or anything else I can use to help the work I'm doing? Perhaps direct it at Kenny, but if anybody else is able to respond as well, please do.
To help the work to get involved in social prescribing, I wonder, could you just repeat that a little bit, please? Yeah,
so somebody who's a psychiatric trainer who's also doing the coaching, has qualifications for medical professionals, working for Senko in schools, doing movement exercise for mental health. I'm just asking, is there any financial support or incentives or anything else that they can use to help the work that they're doing?
I wonder, Catherine might be able to comment on this. I wonder if they go to NASP in the realm of social prescribing, because they're looking at Thriving Communities is a program that National Academy for Social Prescribing has developed. And there are some funding pots there for linking up communities and linking up people and offering training for this space, social prescribing space. So that's one thought.
I'm going to come in with something a bit negative, which is one of the tragedies of social prescribing is that a lot of the provision rather than the signposting is being placed outside of NHS and social care. So within the charity sector and other sectors. That's a whole separate issue. I could easily talk for over an hour on that. And it's not, there's a lot of debate around it, but I would say no, I don't know of any ways to get financial incentive or support other than formally bidding for for projects and social prescribing in the local area, which is a hugely complex, laborious and difficult task. So I would say no, I'm really sorry, I don't know of any.
We can keep looking, I guess, can't we, and push for that. And linked to that is a question around health boards and NHS trusts. So perhaps maybe I can take this one back to Kaz to begin with, but in all health boards and NHS trusts, should there be somebody liaising with the occupational health department to augment and sustain social prescribing?
I'm not sure if me or Catherine, but yeah, neither of us would say no to that. And I think, it would be lovely if everyone in every trust knew exactly how to do the social prescribing in a quick and easy way. So everyone's busy, they have back-to-back clinics. What they need is some brochures, some leaflets, some really quick linking where it doesn't take too much of their time. and to have streamlined processes as much as possible. And then you will find that busy consultants and trainees will engage with it.
Yeah, if I can add, I think one of the complexities of social prescribing is it was very much a grassroots thing that started. So in every area, it's subtly different. So some areas don't have link workers at all. In other areas, the link workers are very embedded in mental health services. In other areas, that role is taken on by someone else. And it's really about the idea behind the link worker is to have this streamlined process that the minute you know how to refer to a link worker, you can just send somebody there and allow them to do the connecting with the individual. But it is different in every area, which is very tricky. And actually NHS England tries to do some mapping to help people. That was one of the first target things they tried to do when they tried to widen the social prescribing, and they gave up very early on because it was just so difficult. So I think any new area you find yourself working in, Google social prescribing in the area and you should get a list of resources and how to signpost people to link workers.
Brilliant, thank you. Thank you. There was one for Kenny, and I think you might have answered it, Kenny, did you?
I did on there, but it might be worth me reiterating that verbally. Someone asked if it was, are you talking about the one about just England?
Yes, that's right, yeah.
Because this is because we're working with NHS England, it is just England for now, and the test pilots early 22 will be just England. However, I think once other nations get a sniff of what's going on, we will be going to those devolved nations to say, this is what you could be doing in healthcare. If they're not already, that is, they might be way ahead of us in England, I don't know. But we are a membership body that is UK wide. So our places are all over the UK. So hopefully that will be going to other nations.
Thanks, Kenny. Another one here, which is, I worked in a day hospital which employed an art and also a dance movement psychotherapist. Why do the panelists think coming across a service like this is so rare?
I really want to answer that because I've been involved for years now with dance movement therapy and the Dance for Health, and it's so beneficial. There's so many resources, so much evidence. And I was talking to the chair of the Dance for Health committee this morning, was telling her about this webinar. And the question was, how can we include dance? I mentioned what you told me yesterday, Kenny, but there's so much more. So I hope after today, we can keep some sort of contact with Catherine and Kenny, and I can definitely connect you with the people who do dance interventions. There's not just for mental health purely, but for cancer, for example, lots of physical health problems. If we think the connection between physical health and mental health, everything is so connected really. We improve mental health, cancer might, the quality of life might be better. So I hope this webinar today is the beginning of a new somehow era for dance for health.
And just as we're finishing, I know we're going to get chucked off in a second, but there is a lovely book called Lifestyle Psychiatry by Noordsky, Noordsky, which really looks at holistically looking at all our patients.
Kaz, thank you so much. And we have unfortunately run out of time, and we haven't managed to get through all the questions, which I just think illustrates how important this topic is and how much we value the work that you're all doing around this. So thank you all very much for taking time to come and speak to us all about this important area. Thank you to all the guests who have come to listen. And I hope that between us, we can drive this hugely important topic forwards. I'd also like to just thank college staff who facilitated the technicalities and organised this webinar for us today. So thank you, everybody. If there are any unanswered questions, we might just send those to the panelists and send them back to the audience if there's a way that we can do that. But thank you. We shall stop there. So thank you, Catherine Kennett. Thank you, Nicoletta Lecker. Thank you, Kenny Butler, and thank you, Kaz Narman.
Thank you.
Thanks, everyone.
Take care.
Bye.